I'm Joelle Carlick. I am an assistant professor and pediatric anesthesiologist at Children's Healthcare of Atlanta and Emory. And today we are discussing one of the more controversial topics in pediatric anesthesia these days, MPO times for clear liquids, and how to minimize aspiration while also minimizing MPO times. I personally have no disclosures other than the fact that I work at a 1-hour clears MPO hospital. I also did maybe debate the pro side last year, but to begin, I would like to review our learning objectives for this session. So first of all, we're just going to review differences in clinical practice in the US and abroad as it pertains to clear liquid fasting guidelines. Then our pro-con speakers will outline the risks and benefits associated with the varying policies. And then finally, by the end of the talk, we hope that you're able to justify your own choice for your own institution. So why are we talking about this topic in general? Because in 2023, the ASA released practice guidelines on perioperative fasting that focused on a few specific topics: carbon protein containing liquids, gum, and pediatric fasting guidelines, particularly for clears. But multiple top pediatric hospitals in the United States and abroad do not follow these guidelines even after this statement. So why? We're going to briefly review these guidelines as they pertain to pediatric patients in case some of the attendees are not familiar with them. So to begin, the ASA group did not find sufficient evidence to recommend a change from 2 hours to 1 hour for clears in pediatric anesthesia. The guidelines also recommended to avoid prolonged fasting as it has physiologic effects. However, they stated that practitioners should use clinical judgment in the setting of shorter fasting times, opening up the possibility to a 1 hour or clears until arrival policy. In the comment section, the guidelines once again point out the unwanted effects of prolonged fasting, but the low quality evidence to support a change in policy. So why are we here trying to convince you otherwise? So as the comment section in the ASA guidelines admit, clinical controversy exists. So let's review who currently follows 1 hour clear times for pediatric patients. Internationally, this includes Australia, New Zealand, Great Britain, Europe, and Canada. And as you can see, some of the countries have employed 1 hour clears times for over 8 years. Some institutions in the US that follow 1 hour's clear times include CHOA, Children's National, Lurie Children's, CHOP, and Stanford. So I just wanted to throw this excellent review paper up here by Zhang in Pediatric Anesthesia from 2023. It's a little bit small, but as you can see, international controversy over MPO times is not just for clear liquids. There are varying times for essentially every category. So to review, the ASA stated in 2023 that there's insufficient evidence concerning the benefits and harms to recommend pediatric patients drink clear liquids until 1 hour versus 2 hours. However, recent papers like this one published in Surgery in 2025 state that further study of more liberal fasting policies is unlikely to find an association. So do we really have enough clinical data, and what does that say? So with those questions, I'd like to introduce our first speaker, Dr. Adam Spencer. So Dr. Spencer is the Section Chief of Pediatric Anesthesia at Alberta Children's Hospital and the Clinical Associate Professor at the University of Calgary Cummings School of Medicine. He also published one of the first ultrasound-based models of gastric volume in 2015, which I've personally used, and qualitative ratings of gastric content seen on ultrasound. Dr. Lerman, representing our Kansai, probably needs no introduction. He is a clinical professor of anesthesiology at the Jacobs School of Medicine and Pediatric Anesthesia Fellowship Director. He has investigated and published on countless topics within pediatric anesthesia and is also the co-editor of the classic pediatric textbook, A Practice of Anesthesia for Infants and Children, among many other books as well. All right. Dr. Spencer.
All right, thank you, Joelle. And sounds like you're on the pro side already, which is fantastic. Just going to set this up here. And that's after debating with you, Dr. Lerman, last year. Okay, this is a great topic, very controversial. Could be argued for hours, but we are given 20 minutes each and will likely be debated forever. Kind kind of ironic, I have to point this out, you've got two Canadians up here fighting about ASA guidelines. Dr. Lerman is Canadian and I'm Canadian, kind of funny. But here he goes. All right, so before I ramble on about fasting guidelines, here are some of the key points I want to convey during this talk. So consequential aspiration, so aspiration events that lead to serious morbidity and mortality is exceptionally rare. Prolonged or excessive fasting is the rule, however. It's not the exception. Improvement initiatives can help, but structural interventions is key to reduce real fasting times. The ASA guidelines ask for more data in the recent revised guidelines that Joelle discussed there. And NeuroFast, new study, delivered. No difference between the 2-hour, the 1-hour, or the sip till send protocol. And what about gastric ultrasound? Its findings are aligned with the aspiration data studies out there as well. So there are physiological benefits from reduced fasting, but these are most important in our youngest and most complex children that we care for. So it's no difference if you've got a healthy 10-year-old who's fasting for an hour or 2 hours or even 6 hours. And I say 6 hours because typical 2-hour policies out there give you an average real fasting time of about 4 to 6 hours. So minimizing fasting reduces pre-op thirst, however, hunger, anxiety, maybe even helps with postoperative nausea, vomiting, and maybe even with pain and emergent agitation as well. It makes that perioperative journey more manageable for kids and their families. So what are the benefits of excessive fasting? I don't think my slide's working. Actually, no, my slide's working. There are none. And a real fasting time of 4 to 6 hours is especially not beneficial to our youngest, most complex patients that we care for. The one thing we know excessive fasting does do is it leads to hangriness. And we've all seen this in the OR, right? On induction especially, or in our holding area. I've seen it at home as well. The issue with fasting rules is that they're really well applied, too well applied. Despite prolonged fasting, we might think, well, at least it ensures an empty stomach. Absolutely not true. This is a study we did 10 years ago. Joelle referred to it. We had a 2-hour fasting protocol at our hospital at the time, but our real fasting time was about 5.5 to 6 hours. Kids were induced for a GI scope. We did gastric ultrasound. We were building that model at the time, and their stomachs were immediately suctioned under visualization by the endoscopist. They had a very strict protocol. They didn't use any fluid in their scopes. It was all air. So we had a very real amount of fluid suction. Overall, kids had a mean of 0.6 mils per kilo of clear fluid contents. One kid actually had 3.6 mils per kilo of clear stomach contents. So about 10% of the group were considered at-risk stomachs, greater than 1.25 mils per kilo sucked out of their overly fasted stomachs. All of them had a gastric ultrasound like this one. You can see in the middle there an antrum that's full of clear fluid. So fasted doesn't mean empty stomach. Years ago, the old adage of being fully NPO after midnight was challenged. Based on some very poor research at the time, but much common sense, the ASA came up with a new concept of allowing pediatric patients clear fluids up to 3 hours preoperatively. But some peds groups out there in Europe felt it didn't go far enough. In 2015, this group from Sweden got the conversation going when they published a really nice retrospective review of their practice. They had a 640 model at the time. They had been using that model for about a decade. This is what we now call sip till send protocol. The incidence of confirmed true aspiration was 3 cases per 10,000. No consequential aspiration events. No cases were canceled. No kids ended up in ICU, and there were no deaths. Interestingly, despite allowing a drink until they were called to the OR, their real fasting time was close to 1.7 hours. So you would think that if you reduce fasting time, you will likely see more cases of regurgitation and aspiration, but not quite. In 2013, Walker published a prospective study with 100,000 patients, including emergency cases, and they found an incidence of about 2 aspiration events per 10,000 cases. But since then, there's been quite a bit of work added to the mix, mostly prospective studies, as you can see in that really nice table there, some looking at 1 hour, 2 hours, and sip-till-sen regimens as well. But overall, the incidence of aspiration goes from very rare, so one per 10,000 cases, to uncommon, which would be about 12 events per 10,000 cases. Consequential aspiration is exceptionally rare. So I work at the Alberta Children's Hospital. We're an academic tertiary care center in Calgary in Alberta, Canada. We've got 11 ORs. We do about 11,000 cases per year. We're doing a lot more remote location cases, just like everyone here, I bet. We realized that a while back that children were excessively fasted, despite our 2-hour regimen. So we looked for ways to improve. We educated staff, offered some training, communicated with families as well, had a video where we actually included some of this information as well. And then we decided to join the many other groups from all over the world and went to the 1-hour clear fluid protocol. And that was about 5 years ago. We now have this algorithm called the Think to Drink protocol. It's very simple. Kids come in, they're admitted to day surgery. If they're more than an hour from their surgery, they're given a clear fluid. The volume is about 3 to 5 mils per kilo. So as I prepared for this talk, I decided to audit a few of my OR days. So time from last sip until induction of anesthesia is what I was looking for. We do have EPIC, so the EMR, so it's very easy to find that type of information. So I noticed a few things right away. A few kids in the morning were often close to meeting the guidelines, 1.5 hours to 2 hours. But as the day went on, this was often derailed for all kinds of reasons. When we're running ahead, the day surgery team, nurses and men, they're no longer offering a drink to the remaining kids because they fear for a fasting violation. If a room got delayed for whatever reason, some of our rooms get bumped with emergency cases. Kids who are already admitted waiting for their surgery weren't offered another drink. So kids near the end of the day, bigger kids, were excessively fasted. But sometimes they're small kids. We've got a list with a lot of small kids on them. I realized how quickly a fasting protocol gets completely derailed. So why are our kids excessively fasted, despite our 1-hour policy? Well, we decided to survey our day surgery nurses, it was anonymous, just to find out if they were offering a drink to the kids as they show up, as per our algorithm. 4% always offer a drink as per our protocol. 52% said no. And this is despite training and their awareness of the protocol. So why not? It's pretty simple. It's logistics. They're busy admitting, pre-medicated, educating, discharging, sometimes running after kids who want to kind of run off from the hospital. Cautiously watching the EMR for finish times and figuring out if a room is ahead or not is simply not a priority for these nurses. They've felt less heat from a team for sending an excessively fasted kid compared to a kid who hasn't fasted for the hour. And we're not an anomaly. This group from Amsterdam decided to do a prospective study of fasting times. They included children and adults. I really like this study because it's mixed facility. They have adults and peds. So you can imagine how confusing things go there, right? So you've got one regimen for kids and one regimen for adults. Despite the 6-4-1 regimen, the median fasting time was 3.6 hours. They had a range of 2.5 to 10 hours. This was kids only. 10 hours would be prolonged excessive. So excessive fasting is the rule rather than the exception. So how has the world navigated prolonged and excessive fasting? So many have attempted to make improvements to the system with some limited success. Others have gone to structural interventions. Here's a recent scoping review by a group from Children's Health Queensland Hospital in Brisbane, Australia. This is really well done, for especially knowing that it's a scoping review. But I want you to remember this group because I'll come back to them a little bit later in the presentation. The group uses a spider chart to show the most common improvement initiatives across the studies. They looked at the average fasting time for clear fluids before and after their intervention. 11 of the 13 studies showed some improvement. Example is a group from California who focused on training communication. They reported the greatest impact. They went from 12 hours to a 6-hour real fasting time, a 50% reduction, but yet in kids, 6 hours is still excessive fasting. As you go through the article, it doesn't take very long. They've got a really nice table that sets up every study with a lot of the important metrics that they looked at. Those getting closest to the goalpost used a structural intervention. They changed their policy. The perioperative environment is so unpredictable because it has so many moving parts. It's no wonder that structural interventions are required to improve real fasting time. This is a really nice study out of Turkey that lays out some of the complexities in getting a patient to the OR. They documented reasons for surgical delays. This is adults and children at this facility. Delays in getting surgical equipment, cases taking longer than expected, surgeons arriving late to the OR, emergency case bumping an elective list. One that I liked is the addition of a procedure when you're in the holding area. You know, you have to change the consent and it'll only take an extra 10 minutes. Yeah, an hour and a half later, you're really derailed. So it's really difficult to keep on top of a fasting policy. And this is due to unpredictability, which creates a culture where excessive fasting is a norm because of its perceived risk. Now, structural intervention through a change in policy is definitely not novel. The first paper I presented showed that the Swedish group had accepted this idea about 20 years ago. And 7 years ago, we had this consensus statement from the European Society of Pediatric Anesthesia saying, you know what, kids should fast for no longer than an hour. Canada jumped on board as well. We released a statement in 2019, and then it was adopted in our guidelines. With publications from Sweden, the Netherlands, Germany, supporting the safety of the 1 hour clear fluid regimen, many asked whether or not there was evidence to support these changes. The European Society of Anesthesiology and Intensive Care, ESAC, completed a comprehensive review using a 3-step process. First time that this was used to assess fasting. They included PICO framework, a systematic literature review using a grade framework, a consensus process including Delphi technique. So they invited leaders from across the world, including the US, including Canada. They've met, they looked at this evidence, and they suggested that the 1 hour clears is the best way to go. And they changed their guidelines as well. From there, other major associations and countries who had their own guidelines changed them as well. You've got the South Africans. No, the French are part of Europe, but Great Britain as well, but they actually changed their guidelines. And New Zealand and Australia. Just to be clear, the European Society of Pediatric Anesthesia, they have a few members. Some groups went further by choosing to move to the Sip-Till-Sen protocol as well. Interestingly, this is a good one. I haven't heard of a group out there who've taken a step back from a 1 hour or a Sip-Till-Sen protocol. But despite this, the 2023 updated ASA guidelines have stayed the course. No changes made due to insufficient evidence, as Joelle remarked. So this past year, the Eurofast study delivered just that, and a bit more, I feel. A prospective multi-center study. They included 31 hospitals across 4 continents, including the US. And I do believe one of the US hospitals included do follow the 1 hour clear fluid policy at the time of the Eurofast. Their primary outcome is a little bit of a mouthful, but they want it to be very specific. So confirmed pulmonary aspiration defined as regurgitation or vomiting of gastric contents leading to respiratory symptoms that require high dependency unit or ICU admission, and gastric content observed in the trachea or radiologic findings typical for aspiration pneumonia. That was their primary outcome. They compared data across the hospitals with the 2 hour, the 1 hour, and the Sip-Till-Sen. They had a total of 300,000 patients as well. There was a total of 420 events, and that was related to regurgitation and aspiration, not just their primary outcome of a true aspiration case. And altogether, their incidence was 9 per 10,000 cases, so very similar to what's been described in the literature to date. The primary outcome of confirmed pulmonary aspiration is at the bottom there of the table and was about 1 per 10,000 cases in each of the regimens. Overall, no difference between the regimens. And also no difference in a subsection that I feel is important, which is escalation of care and ICU admission. No difference between the 3 groups. There were also no deaths, no cardiac arrest due to pulmonary aspiration in any of the groups. The authors had a better look at those confirmed aspiration cases. Unsurprisingly, patients were excessively fasted regardless of the group. So you can see the mean real fasting time for sip till sen was an hour. In the 1 hour regimen, 1.6 hours. And the 2 hours, nearly 7 hours. Weird enough, 76% of patients having an event were in the 2 hour clear fluid group. And although this wasn't statistically significant, that group fared worse, including more of the simple regurgitation, they called it transient, more the escalation of care, and more ICU admissions. That's for the 2 hour group, but again, not statistically significant. But based on this big audit, data favors the 1 hour fasting regimen and also supports the sip till sen protocol over that 2 hour protocol. Now, this wasn't a randomized controlled trial, but at the very least, the Eurofast does provide safety data for the 250,000 kids that were part of the main control group. That was the 1 hour clear fluid group. Interestingly, one of the big contributors to this study was a large American children's hospital who was part of the control group. So here I'm trying to convince you that the 1 hour rule is quite safe, but already many children's hospitals here in the US know that already because they've been using the 1 hour protocol for over 5 years. A survey in 2023 of the Pediatric Anesthesia Leadership Council looked at this issue. 85% of members responded, and 10% were already using a 1 hour cutoff, and 9% were in the process of changing it. Almost 50% reported running into patient care issues, such as hemodynamic instability, hypoglycemia. So not a surprise that 70% agreed that clears should be offered for 1 hour. So why not? This was less about evidence and more about fear, because 3/4 feel their practice should be aligned with ASA's guidelines. And 95% felt that support for the 1 hour rule should be part of the next guidelines. This is 95% of your leaders here in the US. Another survey of over 4,000 SPA members was also done that same year. Now, unfortunately, they got a poor response rate, 10%, typical for a survey. Over 70% feel that a 1 hour policy would be ideal, and a quarter of respondents already had a 1 hour policy, so very reflective of the council survey. Almost 50% regularly experience case delays or cancellations because of clear liquid violations. So what do they do in those cases? Well, a quarter ignore them. They proceed. And then another quarter weigh patient and procedural factors and then decide, which I'm thinking they're probably proceeding but didn't want to say that they were proceeding. And similar to the council, those with a 2 hour clear fluid policy want support from the ASA before switching over to the 1 hour rule. The world is waiting. Sounds like many pediatric sections would love that additional support in writing. So how does gastric ultrasound fit into all this? So most of you have probably been exposed to gastric ultrasound. It's easy to learn. It takes about 5 minutes. It's not perfect, but for the majority of kids, you'll find out if they've got an empty stomach, if they've got clear fluids to be able to regurgitate and aspirate, or if they have solids, which you're dealing with a whole other animal there. And best part is, if you do find that out, you can do something about it. So many gastric ultrasound studies, like the one I presented earlier, shows us that even the very fasted, healthy kids show up with larger volumes of stomach contents. There are also studies like this one looking at transient times of various liquids. This is a nice one. I like it because these kids are booked for surgery. So they come in, they might be anxious. They come in with all the typical baggage of a healthy elective surgery kid. One group received 3 mils per kilo, while the other 5 mils per kilo of a sugared solution. They scanned every 5 minutes until they got back to baseline. Similar to previous studies, regardless if the kids got 3 or 5, they were back to baseline within about 50 minutes. What about beyond the 5 mils per kilo? Well, a few studies have shown that at 7 mils per kilo, many kids won't get back to baseline. So 3 to 5 mils per kilo is kind of the evidence out there to stay within that limit. So we should probably limit it to the 5. Gastric ultrasound has shown us that about 1 in 10 of your healthy kids will get to the OR with about 1.5 mils per kilo of stomach contents. So you can call that an at-risk stomach. On that same note, studies have shown us that healthy kids can also regurgitate and also aspirate, but it's exceptionally rare for them to do so. But where gastric ultrasound, of course, comes in to play is when you suspect a possible full stomach. So gastric ultrasound and the big data studies are aligned and point to the similar patient risk factors. So who's at risk? Emergency surgery, especially abdominal surgery, kids with pain or kids who come in who've received opioids, diabetics, and those on GLP-1 agonists. I've had a number of those types of patients show up. We scan them, and they've got a full stomach. Suspected fasting violations as well. So there's a number of risk factors there that you can use to determine, should I ultrasound and do something about it? In these at-risk groups, why not use this tool before you take off, or at least if you can't do anything and you have to proceed, before landing? Okay, I wanted you to remember that Queensland group. So that's the group that actually completed that extensive scoping review. They were looking to see what they should do at home. And after their extensive review of the literature, they decided to go with a sip till send protocol. Max amount, 3 to 5 mils per kilo. When they're ready for the kid to come to the OR, no more sipping. Gives you about 45 minutes to an hour. Simple, very little to confuse. And that's the end of my talk. Thank you.
Good morning, ladies and gentlemen. My position is that the 2-hour fast has been in place for about 35 years. And so what are we looking to accomplish by changing it? I mean, change is good, but are children going to be safer and better cared for if you reduce the fasting interval or eliminate the fasting interval after clears? In contrast to the data presented just now, nobody ever argued that aspiration was a risk. In fact, in 1948, when Mendelssohn described aspiration in OB patients, not one of the deaths occurred in women who aspirated clear fluids. It was only solids, where they couldn't extricate the solid material from the bronchi. So nobody has ever suggested that having clear fluids up until the time of surgery, or close to it, is an aspiration risk. But changing the policy, as we've seen, nicely demonstrated, is a major undertaking. And having nurses and parents who are juggling children and a variety of other extraneous factors try and give fluids closer to the time of surgery, let alone get the kids to the hospital and in the OR, is a major challenge. Nurses don't have time to invoke a 1-hour fast and watch the schedule, as Adam eloquently presented. So why put added burden on them? Because I said in my editorial you're going to see in a moment, this is really much ado about nothing. Nothing. Because having a child drink a little bit of fluid preoperatively, especially if they're already near or in the hospital where they can't access solid food, so who cares if they're hungry, it's too late, is not going to restore euvolemia. And Seeger and Holliday, you remember, were the ones who proposed the 4-2-1 rule in 1956, I think, argued in 2004, oh, we really made a mistake. 4-2-1 rule wasn't intended for the operating room. You should be giving 10 cc's per kilo IV to every child who gets an IV who comes to surgery to turn off ADH. And that is our IV fluid management intraoperatively. So giving the children a wee bit of fluid preoperatively actually serves no benefit. And so while I'm not not canceling a child who drank less than 2 hours, an hour and a half before surgery, had some clears to go full-blown and worry about which children has delayed gastric emptying for a variety of factors, some of which Adam mentioned, but many others, is too much paperwork. It's too much issue, because they are not going to drink enough preoperative fluids to restore euvolemia. That is the essence of the argument. The Europeans began their studies, you saw, 2015, saying that prolonged fasting is horrible. Really? Kids fast overnight, sometimes 12 and 15 hours all the time, and my kids and grandkids have never been disturbed by an overnight fast. Why would they be coming to the operating room? The answer is they're really not. So I have nothing to disclose, and let me show you my few slides. How is a 1 hour fast very different than a 2 hour fast, or better? In fact, it isn't better. Whoops. And does it make anesthesia safer? So why consider a new policy when the old policy has worked? At least aspiration isn't a problem. If you think that is, I don't. Prolonged fasting, is that an issue that bothers you and keeps you up all night before you come to the operating room? Personally, I don't think that's an issue. And what about how much oral fluids they're going to have beforehand and whether the parents are compliant? But is it the parents and their education and training, as all of you were probably told before you came to surgery, nothing after midnight, just applying the same principle to their children because they're afraid the child will be canceled? And lastly, are intraoperative fluids an issue? So I've sort of suggested all of those answers already. As we saw, the ASA concluded in 2023, including the data from Europe, that there really wasn't enough evidence to suggest there was a reason to change the fasting interval. The ASA guidelines are about 2 years old, as you can tell, but the issue is they're conservative, and as anesthesiologists, we're conservative in almost every state. An aspiration is a reportable state issue that it gets investigated. And then, as I said several years ago, the European group came to the proposal of guidelines for all of Europe for clear fluids in children. And this was based on a synopsis of a lot of research, much of which they've cited. What you don't know is that I happen to be one of the reviewers of these guidelines. And I made a number of constructive comments, most of which were ignored. And one of the handling editors then turned to me and said, would you write an editorial? Now, you have to understand, perhaps unlike the ASA guidelines, European guidelines are unlike the Bible. When you write it, it is what's written on paper and you don't criticize. I eviscerated these guidelines based on the science behind it. The editor-in-chief, because it was an invited commentary, was forced to accept my guidelines, but negotiated with me to delay publication for 3 to 4 months so it didn't embarrass the ESA because of these guidelines. And so many are unaware that I even wrote a commentary. Again, the title was Much Ado About Nothing. And in it, I went through each of the issues that the authors raised about prolonged fasting, like ketoacidosis, hypoglycemia, difficulty putting in IVs, difficulty with hypotension, most of which have been individually studied and shown not to be true. A 1 hour fast, they said, will prevent ketoacidosis. Well, actually, kids who fast don't get ketoacidosis. They get a slight increase in ketones, but that's not the implication of what their guidelines suggested. Same with hypoglycemia. Same with IV insertion. And finally, hypotension. So, but are the kids really unhappy coming to surgery? Not really. The evidence is pretty clear. The studies have been done, and some of the, I don't think I included any of them, to show that actually kids aren't that unhappy because they often wake up in the morning and they don't rush to get a drink, as you'll see in a second. And you can use distraction techniques. But let's go to the actual data behind these ESA guidelines, prospective studies, and I just have time to show you one. This was the pivotal first study by Schmidt, where they looked at a 2-hour fast and a 1-hour fast. That's the title, Gastric Fluid Variables after a 1 and 2-hour fast, published in the British Journal of Anesthesia. And there's the vertical magenta bar at each of those times. You don't have to check your glasses if they're blurry or not. You'll find no data points on either of those two fasting periods. In fact, 0 children fasted for 1 hour, 0 children fasted for 2 hours. And yet, the title was not changed to about 1 hour or almost 1 hour. I can't believe that the editors at British Journal of Anesthesia could allow a paper like this to get published, where no data supported the hypothesis, the title, or anything else in the paper. I'm not disagreeing with their finding. They're actually finding that they had similar gastric fluid volumes, but nobody fasted for an hour. This is the science. 0. And in fact, I just drew an arbitrary bar at 1 cc per kilo, and there was a statistically significant greater number of children with gastric fluid volumes in the 1-hour group, or under one-ish hours, with gastric fluid volumes greater than 2 hours. I'll just speak to that in a second, because it doesn't portend aspiration, but it's going in the wrong direction. And then the same groups of authors published a current opinion in anesthesiology, where they listed all their papers, most of which they published, of gastric fluid volumes, and fasting times, and said there was really a weak correlation between fasting interval and gastric fluid volume. A weak association. Well, not being one to walk away from a challenge, I took their data and I graphed it. And you can see an R-squared value of 0.9, which is not surprising, since gastric emptying is exponentially related to gastric fluid volume of clears, showed an extremely tight correlation for which you almost never see similar results in science, clinical science. So, does gastric fluid volume increase as you fast less? Yes. Does that mean anything? Really not. Aspiration is so rare. But let's move on, because this is the science upon which these guidelines were based. Is gastric emptying reliable? Well, it's quite variable. Look at how these studies by groups involved in this research in Europe showed the differences in gastric fluid volumes. 95% confidence intervals were huge, up to a half time of an hour. And in this study by Schmitz, this group, look at the variability in the gastric emptying times of a pre-op fluid volume of 7 cc's per kilo. It's very variable. Personally, I want to deal with a 95% confidence interval and have no kids with fluids in their stomach. I don't want to think about it because I am doing an inhalation induction. Europeans tend to do IV inductions. Inhalational inductions, IV inductions. Not the same, and not necessarily with trainees who may get themselves into trouble. And then we heard about the Eurofast, a huge number of patients, over 300,000. Multi-center trial looked at fasting, and I'm not going to repeat it all, except to say that aspiration was non-inferior amongst the 3 groups, not surprising, and that the duration of fasting wasn't actually reported, but one of the centers reported 100 in 10,000 incidents of regurgitation. What's going on? One of the standards was a standout. There's not a homogeneous practice in Europe when that happens. And possible aspiration, curiously, was threefold greater in the 2-hour fasting group. Threefold, 30 per 100,000. Now, how does that come to pass? I can't remember the last time I saw an aspiration or a regurgitation even in my ORs. So there's something weird about this, but this speaks to one very important fact that nobody has talked about, which is the Heisenberg principle. Once you perturb a system, once you do things like change the policy, make a 1-hour fast, you are going to have compliance, you're going to have eyes on it, you're going to have everything working smoothly. But the 2-hour fast groups were probably always fasting 2 hours. So there was no change in policy. There were no extra eyes monitoring what was going on. And so you would expect a better outcome when you perturb the system and introduce a new plan, which is what I think happened here. So why do we parents think we fast children preoperatively? Have you ever asked parents that? Well, there's been at least 2 studies, probably more, and the answer is they don't know why. They got all kinds of reasons, but many of them, 42% in single studies, said, we don't know. They fast maybe to reduce vomiting, prevent nausea, vomiting. That's not the case. Parents don't know why they fast, but they do know that if the kid isn't fasted, they're probably going to be canceled. Now, the people who are the gatekeepers to the fluids are the adults. They're the parents, you and me. And what are you told before your surgery? NPO midnight. And that's what they have in their head. And they think it's no different for their children, so they often fast the children just to be sure they don't get canceled. And here's a study just published a couple years ago in JAMA Surgery, talking about liberalizing fluids for adults coming to surgery to 1 hour, like a new concept. But the adults were only allowed 150 cc's, 1 cup of water per hour. A picayune dose of water. And they said it looks like it's working and it's going to be good. So it's no surprise that adults who are used to fasting are told to fast before their surgery, do the same thing for their children. And until you change the adult attitude, you're not going to change any fast, whether it's 2 hours or 1 hour. So does a 1 hour fast prevent prolonged fasts? And I think we saw this data already, and you can see in this group, 1 hour fast, 0 for clears, 1 or 2 hours. They still had 5 hours as a 25 percentile of children who were fasted, and the range was to 28 hours. It doesn't eliminate prolonged fast. Lord, if that's what you're trying to accomplish, you need to do something more strategic. And when asked about why the children in that study didn't get their fluids 1 hour preoperatively, look at the answers. 15% of the parents said the kids were sleeping. 40% of the kids refused clear fluids, probably because they were playing preoperatively and had some life people there giving them games, and others were non-specified. But the bottom line is, it wasn't because there was a reluctance to give them fluid. And so what did Thomaso in France do to solve this question? They didn't reduce their fasting interval, because that's really a silly thing to eliminate prolonged fasting. They sent text messages to every parent at the end of the day before surgery, 4 to 5 p.m. And they reduced the fasting interval of clears from 6 to 2 hours. And you can see here on the right side, 93% of the parents were compliant with their 2 to 3 hour clear fluids fast preoperatively. You need to do something proactive, not passive, like reducing the fasting interval. You need to get on the parents, because the parents have a pile of papers from the hospital, from the surgeons, from the nursing department that tell them what to do, and they're not going to read it all. They forget it all. The day of surgery, they just want to get their child to the operating room and get the surgery over with. So what are the questions I'm going to leave you with? How do you educate parents to ensure that children drink, whether it's 1 or 2 hours? The answer isn't just changing the fasting time. That's a moving target. Children can't drink enough preoperatively to restore euvolemia. We don't want them drinking 10 cc's per kilo of clear fluids. What we do want you to do is give IV fluids at least 10 cc's per kilo per hour so you restore euvolemia. And if children are allowed to drink until 1 hour pre-op or until they're called to the OR, who is going to monitor it? Who is going to limit the volume and ensure that the right types of fluid are ingested? So should we consider a new policy of 1 hour? Aspiration is not the end point, so please stop talking about it. Is prolonged fasting really an issue that's detrimental to a child's well-being? Has any child who's been prolonged fast not had surgery but gone to the ICU? The answer is no. Come on, let's get real. Those of us who do anesthesia know it. How about oral pre-op fluids? Not the case. But are parental education and changing parents' attitudes the problem? Absolutely yes. So we need to keep it simple, keep it safe, and institute policies that will have a benefit if you're concerned about the detrimental effects of prolonged fasting. Thank you.
All right. Usually there are plenty of questions, so if people want to start coming up, our speakers can start again. We've got about 10 minutes.
I'm Steve Smith. I practice office-based anesthesia in Missouri. And my concern, the science is muddled, but my concern is the ASA, by keeping the 2-hour limit, says that if I anesthetize a child that's had something to drink within that 2 hours, I've committed malpractice. The first thing a plaintiff's attorney, if I did have an aspiration case and it did go to trial, attorney, the first thing he's going to ask is, are you aware your ASA says that you have to wait 2 hours after clear liquids? And I said, well, yes, I am. Well, there you have it. I'm guilty. And I think the ASA, who I've supported my entire 40 years of practice, has got a noose around my neck. And by keeping the 2-hour limit, if it's not clear that I've committed malpractice, it doesn't matter. And that's my
Well, that's true about all ASA guidelines. Same with GLP-1 drugs. I mean, I was just in the panel and had a big argument with Joshi about the GLP-1 holding guidelines, because they all are now of the firm opinion we don't withhold GLP-1 drugs before anesthesia and give them clear fluids, even though, as they concede, it takes about 2 years for the ASA to change their guidelines. So, yeah, I mean, but when it changes to 1 hour, if it does, how is that going to affect you? Well, if the child is fasted only 45 minutes, you're going to run into the same problem. But it's a moving target. And you're right, you can't go against ASA guidelines.
Yeah, it's handcuffs, and we're stuck with it. But
you are until the next guidelines come out.
This is a little bit of a similar situation in Canada where, of course, not as litigious, that's for sure. But we waited for CAS, Canadian Anesthesia Society, to publish the guidelines supporting the practice that was present in the country. So same kind of questions were asked. Hey, you know what? We're going against the guidelines. The guidelines should support us. That's one of the points I was making. When you see these big systems here, pediatric healthcare centers that are doing a 1 hour fast already, why not just go with the flow? Because many parts of the world is actually doing it already, especially if you're not worried about aspiration.
But remember, it doesn't matter really what the guidelines are. When your individual case goes to court and somebody digs up a gastroenterologist's assessment that this child, for some congenital or unknown anomaly, has some evidence of delayed gastric emptying, you're dead. I don't care what the guidelines said. You let the kid drink and you anesthetize them. But I found a note in the chart somewhere that the child had been investigated or questioned whether or not they had delayed gastric emptying. That puts you back on the hot spot. And that's part of the problem. We can't screen the kids who come to the OR for what might be considered or has been considered a delayed gastric emptying. And
Although
we're
you
not going to
can-
gastric ultrasound.
You can use gastric ultrasound.
We don't have time. We do 85 outpatients.
Not for everyone.
Outpatients a
Not
day.
for everyone, that's for sure. Yeah.
Okay. I don't consider the ASA as having a noose around my neck. I consider that they have a safety net under my feet, but, difference of opinions. Adam, for you, I'm sort of a cynic, and I have always sort of operated on the principle of beware the wisdom of crowds. And I worry that, can you comment on surveys being considered science? So, because you had, the leaders of the ASA, I mean, there was this
the survey.
scientific survey, and then there was another scientific survey. I think to say a scientific survey is an oxymoron.
Oh, I completely agree. Survey is meant to really describe, for instance, in those cases, practice. So in those cases, there was a number of, I think it was 25% in both groups that were saying, we practice 1 hour clear fluid rules already. So that's what the survey said. I mean, the leader council survey, I think would be a little stronger than the SPA survey just because of the very poor response rate. But I completely agree. In that case, that those surveys are more, environmental scan, if you will. Oh, of course. That's why I'm here. Yeah, that's true. But again, it kind of speaks to the fact that there are many different hospitals here in the U.S. that use 1 hour clears, and they've been using them for more than 5 years. I know one of my colleagues used to be at CHOP and mentioned, I think it was 2017, that CHOP actually adopted 1 hour clear fluids, which is amazing. They haven't gone back. So
Have they ever checked how many children have prolonged fasts in those institutions? Let's face it. The question is, what are you trying to stamp out by changing to a 1 hour fast, as I said in my talk? If you're concerned about prolonged fasting, show me that CHOP before the 1 hour fast had prolonged fasts and that's been attenuated since.
But now many studies have shown that, right? You go from 2 hour to 1 hour, and you go from about a 2 hour, which was about 6, and a 1, which is, these are false premises almost, right? Like 1 hour actually equals 3 or 4, and a 2 hour is 6 or 7, and a 0 is actually what we want.
But that's because of the parents
Sip and
not
sip.
giving the fluids.
Although they've tried that as well,
So we need
yes.
to educate the parents. Let's get to the
Now,
issue.
That's a good one as well. I actually did my fellowship in France, and France is very homogenous. So if you think about texting, I think about Calgary, very, very diverse. Many of our families do not speak English. Now you have to text in a way to make sure, there's a lot of issues with texting families as well, to get that communication actually through. So that, again, sip till send, we're not there. But I think that's where it's going.
Good morning. Thanks for this excellent debate. I'm Magdi Qatar from UK, United Kingdom. I work in a very busy tertiary children center. Up till last week, I was supporting Adam for the 1 hour or still send. But today, I'm really convinced that parent education and ward staff education and even the children themselves education is very important, and I should go back again to the traditional 2 hours fast from clear fluid before theater, before operation.
Well,
I think
that's interesting that you would say that. My colleague in Sweden has said that in, I think, the Anderson original paper, that institution has gone away from, I think they had a 0 hour or 1 hour fast, gone away from it over the intervening period, but they don't write that. You see, that is a bit of misleading data because it's left hanging in the literature, but changes have not been followed up.
absolutely right, because the ABA late, the one before the last recommendation was 0 hour fast, but now I think the changing it, gray line to go back again to 1 hour or even 2 hours. And now we are the UK now, it's not European anymore. So I think they're going to be back again for a 2 hour limit. Thank you.
Interesting.
I shall be following that. I'd like to see their guidelines go back to 2 hours. That would be very interesting to see, for sure.
Jeff Ploganoff, past president of ASA, and having done pediatric dental anesthesia only for the last 5 years, I find this very interesting. Thank you. And I saw the debate a few years ago, too. It's fun because we debate it within our groups. We've got a database of over 350,000 cases, no deaths, very strict on everything impacting safety and quality, but we fight over this issue. In my first quality meeting with the company, which was 5.5 years ago, I said to my wife, oh gosh, I'm going to get fired before I even start. Because I was opposing the founder on something. We had a kid, I think they were going way too liberal on the solid side of things, and I don't like what the ASA's guidelines are saying a light meal, because I like to say a light meal is about as vague as you can get. Some people, a light meal is one pizza with a bunch of, there's one pizza with fatty meat and cheese on it. I'm good, thank you.
Okay.